Alrighty. Okay, couple quick things. One, I didn't get to grade yesterday like I typically did, just had a whole bunch of stuff happen, so I'll catch up later this week, so y'all will be on top of all your grading and whatnot. Thank you to the couple of people who have emailed me to ask about the very confusing wording about the media project. Once upon a time, for the media project, I had folks turn it in both in person and on Blackboard. And now I'm just having you do it on Blackboard, but apparently I left the language about turning it in both ways. And so a couple of people have emailed me and been like, what the heck do you mean by both ways? And I'm like, fair. So you only have to turn it in on Blackboard, so ignore where it says turning it in both ways. But do turn it in all in either one Word or PDF document. So, and then that is technically due today. Again, remember, there are no late, I was gonna say no late fees, this isn't Blockbuster. But there are no late penalties. So just get it in when you can. I'd rather read a good one than an on-time one, if that makes sense. So do what you need to do to get that done and get it done well. But obviously, if you have it done, turn it in on Blackboard and do not worry about turning it in both ways, because that's not a thing anymore. And like I said, I'll try to catch up on grading exams and getting, for some people, for whatever reason, Connect still isn't syncing, not Connect, Launchpad still isn't syncing. So I have to hand go in and make sure your grades get over in Blackboard, so I'll do that later this week as well. Any questions about this? The other thing not to forget about is your group projects. We're about a month out from exams, believe it or not. So we will very soon be, you all will be presenting, because that is during our exam time. So make sure that you're thinking about working with your group. If you need me to remind you who's in your group or point them out, if it's someone you haven't met before, just let me know. I'm glad to do that. And then within the next coming weeks, I also want the group to meet with me as a group, so that we can make sure everybody's on the same page, make sure you're ready. I give you feedback in terms of either, whoa, you're trying to cover too much information, or, oh, you should probably flesh this out a little bit, that type of thing. But yeah, I just want to remind people so that doesn't slip off your radar. Alrighty. Okay. So today we will finish working our way through the sexual disorders, which I believe, will get us back on schedule. So then we'll cover schizophrenia Thursday and a week from today. And what I've been doing is going through and just making sure we have some good videos to illustrate everything. So I've added lots of links for those, which will hopefully help illuminate some of this for y'all. Righty. I'm just gonna skip ahead to where we were. Okay, we were talking about disorders of excitement and arousal. And so this is going to focus in on the excitement phase of the sexual response cycle. And it's marked by changes in the pelvic region and general physical arousal. And also things like increases in heart rate, muscle tension, blood pressure, and rate of breathing. In men, we see the erection of the penis. In women, we see the swelling of the clitoris and labia, as well as vaginal lubrication. So now we're going to talk about some fun old language. And by fun, I hope you can hear the sarcasm dripping off their voice. So female sexual interest / arousal disorder used to be called frigidity. So the idea is anyone wasn't interested in sex, she was frigid. She was an ice queen. So this is characterized by repeated inability to maintain proper lubrication or genital swelling, if we're focusing in on the arousal phase. And many with this disorder will also have like an orgasmic disorder, which we'll talk about in a few slides. It's estimated that more than 10% of women experience this disorder. So that's a lot, right? Where a lot of the disorders we're talking about this sort of back half of the semester are only like 1 or 2%, right? That's a lot. And because this disorder is often tied to an orgasmic disorder, researchers will study them together. So now we're kind of studying excitement, arousal, and orgasmic all together for women. Male erectile disorder, which you'll sometimes just see abbreviated ED. This used to be called just impotence. And this is characterized by repeated inability to attain or maintain an adequate erection during sexual activity, or a decrease in erectile rigidity that interferes with sexual activity for at least 6 months or more. And again, 10% of men experience this disorder, so this is not that uncommon. According to surveys, half of all adult men have erectile difficulty during intercourse at least some of the time. And most cases of erectile dysfunction or disorder result from an interaction of biological, psychological, and sociocultural causes. So even minor physical impairment of the erection response may make a man vulnerable to the effects of the psychosocial factors. So like if you're having any kind of erectile disorder, a lot of things start going in your head, basically, related to it. And in terms of biological causes, the same hormonal imbalances that can affect desire can also produce erectile disorder. Most commonly, however, some sort of vascular problems are related. So it might be high blood pressure, high cholesterol, things along those lines. It can also be caused by damage to the nervous system from various diseases, disorders, or injuries. So for example, during my first rotation on my residency, I worked on a spinal cord injury unit. And one of the things that my supervisor had sort of taken on herself was to talk to the veterans about erectile dysfunction and sexual functioning, because none of the MDs would do that. And a lot of them were having issues because they have a spinal injury, and so they had nerve issues there. And so there are all kinds of things like shots and penis pumps and pills you can do so that they can engage in sexual activity. But unfortunately, and this is not just like men who experience this, but in general, people who have disabilities, we don't think of them as sexual. And so we don't talk about that stuff with them, which can be problematic. The same cause, actually, this is like random fun fact, like older adults, we don't necessarily talk to them about like safe sex. And so in some senior living facilities, we actually see rampant sexually transmitted diseases because when someone's, spouse of many, many years passes away and they've been monogamous and they didn't have comprehensive sex ed growing up, and then they just start trying to experiment, you get a lot of venereal diseases passed around. So, we do need to be educating and asking. Let's see, the use of certain medications and substances can also interfere with the ability to get or maintain an erection. And medical devices have been developed for diagnosing the biological causes of ED. So one of the strategies is up here, the nocturnal penitomosins. And what this is that men typically get erections during REM sleep. And so during a sleep study, in addition to putting on, everything to monitor your heart and your breathing and your brain activity, they would also put this on the penis and measure whether or not an erection is coming during REM. And if it's not, then we know that there's a physical basis for the erectile disorder. But obviously psychological causes can be involved here too. So as many as 90% of men with severe depression experience some degree of erectile disorder. And one well-supported cognitive explanation for ED involves what's called performance anxiety in the spectator role. And you'll hear me mention this several other times as we talk about the sexual dysfunctions. So once a man begins to have any kind of erectile difficulties, he becomes fearful and worried that it will happen again during sexual encounters. And so instead of being a participant, he's like a spectator and a judge of himself, basically. And this can create a vicious cycle where the original cause becomes less important than this sort of fear of failure and looking at yourself from the outside in. And then in terms of sociocultural causes, all sorts of different things, job and marital distress seem to be particularly relevant here. All right, so next we're going to talk about disorders of orgasm, and obviously this is the orgasm phase of the sexual response cycle. So premature ejaculation is now referred to as early ejaculation, and it's characterized by persistent reaching of orgasm and ejaculation with little sexual stimulation. And about 30%, so we're up to almost a third of men experience premature ejaculation at some point. Psychological and in particular behavioral explanations of this disorder have the most support. So it seems like what happens is essentially because unfortunately our society is really weird about sex, people masturbate in private and they're like just trying to get it done as quick as possible so no one discovers them. And so it's like they teach themselves to orgasm really quickly, inadvertently. And this dysfunction seems to be most typical of young, sexually inexperienced men, but it also may be related to anxiety or poor recognition of arousal. There's a growing belief among many theorists that biological factors may also be playing a key role in this disorder. One theory states that there might be a genetic predisposition to early ejaculation. A second theory argues that the brains of men with rapid ejaculation might contain certain serotonin receptors that are overactive, and then perhaps others that are underactive. A third explanation holds that men with this dysfunction experience greater sensitivity or nerve conduction in the area of their penis, which again would be a genetic thing. And then we have another disorder that used to be called male orgasmic disorder, and it's now just called delayed ejaculation. So now we have early ejaculation and delayed ejaculation. And I'm just gonna pause real quick here and make sure I actually have the new terms on here. So that we're all on the same page. Don't think they changed female orgasmic disorder, but let me double check while I'm doing this. They did not. Okay. Back into our slideshow. Okay. So delayed ejaculation is characterized by a repeated inability to reach orgasm or by a very delayed orgasm after normal sexual excitement. This is a little less common, but still occurs in 8% of the population. Biological causes here seem to be linked to low levels of testosterone, neurological diseases, and head or spinal cord injuries. However, medications such as certain antidepressants like SSRIs and drugs that slow down the central nervous system can also be implicated here. A leading psychological cause, just like ED, seems to be performance anxiety in the spectator role. The idea that, again, you're like seeing it from outside and not letting yourself be in the moment and enjoy things. Another psychological factor, just like early ejaculation, maybe past masturbation habits, or maybe you've masturbated very slowly. And this disorder may also end up developing out of like a desire disorder. Then there's female orgasmic disorder, and this is characterized by persistent delay in or absence of orgasm following normal sexual excitement. And a quarter of women, about 25% of women, appear to have this problem. 10% or more women have never reached orgasm. It's really sad to me. And an additional 10% only reach orgasm rarely. So one thing I will say here, and this could be true of many of the other disorders we're talking about as well, but for women in particular, unfortunately, the messages and scripts we get in our society for like how the sexual response cycle is supposed to work from movies, from porn, from romance novels are very deceptive. And basically modern research has shown that all orgasms are pretty much clitoral orgasms. So if you're engaging in sex and there's no clitoral stimulation and you're not orgasming, it does not mean there's anything wrong with you. Right? It means that you're not actually getting physically aroused because no, you're not getting stimulated there. Really interesting sidebar is that even the G-spot, sort of always seen as this mythical thing, seems to be where the outer, I guess the inner outer structure of the clitoris connects to the vaginal wall. So the clitoris is much more powerful and much bigger than we think. It has a large interior structure as well. And same thing for men, you know, if they're just not actually getting stimulation when you're having sex and they're not orgasming, that doesn't mean they have a disorder, right? It means they're not getting stimulation. So women who are more sexually assertive and more comfortable with masturbation, talk to their partner about what works for them, tend to have orgasms more regularly. This is probably like not surprising to anyone in this room. Female orgasmic disorder is more common in single women than married or cohabiting women. And most clinicians agree that orgasm during intercourse is not mandatory for normal sexual functioning. So that's another side of this is like, if the person doesn't care that they're not orgasming, it's not a dysfunction, right? But if it's bothering the person, we need to look into it. This is also, as I mentioned previously, linked to the arousal and desire disorders. And in terms of biological causes, there are a variety of physical conditions that can affect a woman's arousal and orgasm. Things like diabetes, things like multiple sclerosis, which has a higher incidence in women than in men, can affect it as well. The same medications and illegal substances that affect erection in men can affect arousal and orgasm in women. And postmenopausal changes may also be responsible, although some research suggests that women feel like their sex life actually improves after menopause. Although I would guess that is more sociocultural and psychological because it's like the fear of getting pregnant is gone. So psychological causes here seem to be things like memories of childhood trauma, relationship distress, right? Like if you're fighting with someone all the time, unless you're having like anger sex, right? It's sort of hard to engage in a healthy sexual relationship with them. Some sociocultural issues here. For decades, the leading sociocultural theory here was that it was resulting from sexually restrictive cultural messages, but this theory has been challenged because sexually restrictive histories are equally common in women with and without these disorders. And cultural messages about female sexuality have been changing somewhat, while the rate of female sexual dysfunction stays consistent. However, researchers suggest that unusually stressful events, traumas, or relationship issues may produce the fears, memories, and attitudes that characterize these dysfunctions. And research has also linked certain qualities in women's intimate relationships, like emotional intimacy, to orgasmic behavior. So like you may be more likely to orgasm if you feel an emotional connection with your partner. I also sort of wonder about like third variables there, like Maybe it's just if you're more emotionally linked to your partner, you might feel more comfortable talking about what you want, or they might engage more in things that might make you feel better. For all of these as well, and I think I have notes about this later. One of the things that is problematic for folks is if you're raised very conservative, right? And it does not matter what religion, Christianity, Judaism, Islam. I think pagans are pretty liberal about sex, probably not paganism, but if you raise in any kind of religion or other cultural messages about sex being bad and dirty, and it's something you don't do until you get married to that one person you'll have sex with for the rest of your life. Sometimes people have a really hard time getting over that. The movie, I think it's Forgetting Sarah Marshall, Kenneth the Page from 30 Rock is in it, and his character has this. He's playing a young married husband who feels very uncomfortable having sex because he's always been taught it's wrong, right? And so of course they have some funny bits where he pretends Jesus is in the room, and no, it works for him, right? But for some people, it's not funny. It's really hard for them to sort of work past this idea they've been told all their life that don't do this. So that can affect all of these things as well. All right, the next thing I do have a quick video about this one.
Orgasms or lack thereof.
Maybe we'll have sounds.
Not funny. If you have never had an orgasm, keep watching this video. Today we are talking about female orgasmic disorder, also sometimes called anorgasmia. This is characterized by either delay.
Like this. Hey, there we go.
Orgasms or lack thereof.
Yeah, so this is sort of a goofy YouTuber, but at least gives you some ideas about this.
Orgasms or lack thereof. Not funny. If you have never had an orgasm, keep watching this video. Today we are talking about female orgasmic disorder, also sometimes called anorgasmia. This is characterized by either delay in frequency or absence of orgasm, or decreased intensity of orgasmic sensations in 75 to 100% of all sexual encounters, and causing significant distress. And yes, it can be very distressing. Now, there are varying stats in terms of the frequency of female orgasmic disorder. What I see most commonly is 15% or 1 in 10, so somewhere between 10 and 15% of all women. However, I believe that this is probably more a reflection of North American or Western standards. There was one study done by the International Society of Sexual Medicine, and they said that rates even within the Western world, within Europe and then North, Central, and South America, rates were closer to 16 to 24% of women. And then within Asia, the rates were actually between 30 to 46% of women were experiencing female orgasmic disorder. Sorry there was no mention of Africa or Oceania in that particular study, but I know that you guys are having sex too. Perhaps you are orgasming every time, in which case, kudos to all of you down under. But if you are having sex and you're living in one of those continents and you are not having orgasms, don't worry, you are not alone. The rest of us are neither. It is actually very common, regardless of which stats we are looking at. Even 1 in 10 is still quite a few women that are experiencing this worldwide. And there are a lot of different factors that we look at. As a sex therapist, I always consider biological, psychological, sociocultural, intergenerational, and relational issues that contribute to not being able to orgasm. So getting to the root of why you specifically may be dealing with this in your life right now is a very personal experience and exploration that I would highly recommend talking to a counselor or a sex therapist about. I actually do one-on-one online counseling within North America, and so if you do live in thing that I think would be important.
Just skip past her ad because we're good there.
For all females to hear, really, whether you're orgasming or not at this point, it would be this. We are grossly undereducated when it comes to female sexuality and arousal. I mean, sex in general, we get shortchanged on in the education department for sure, but female bodies and their arousal process in particular is almost non-existent from any sort of formal reputable curriculum. If you are getting sex education, it's kind of like, here's your fallopian tubes and this is your period, and wear a condom so you don't get knocked up, and syphilis sucks. But absolutely nothing on arousal or pleasure or joy that can come from sexual union and experiences. I've beefed about this before on this channel, and to be honest, I will probably beef about it again, but we need better sex education. I will create curriculum. Anyways, to make matters worse, the sex that we then see portrayed in mainstream media, movies, and porn follows the male arousal process. So we don't get formal education on what arousal is and what that looks like, and then the only images that we really get exposed to are very penis centric, and all of the women in these images just seem completely attuned to this penis process that's completely unrealistic. So generally speaking, that is the male arousal process. It is a slow linear climb to orgasm, and then there is orgasm, and then there is like decline. Orgasm is gone, arousal is gone. Now, it actually is possible for men to experience multiple orgasms, which is something else that is left out of sex education for male bodies that would be beneficial for them to know about, but I will save that for another video coming to you soon. But for the sake of this video, we are going to talk about that male arousal process, which is we get steamed up, we come, and then the sex, she is done. And that actually does work for most men, and so it is expected that that should also...
So this is just gonna go into like some more detail about the arousal process, but I just thought it was helpful to see someone who's not me kind of articulating some of these ideas. But then I found a couple videos of people who actually struggle with these disorders, which I think, again, it's often more educational.
The following program contains mature subject matter. Viewer discretion is advised.
Do you know a woman will experience close to 2,000 orgasms throughout her lifetime, while the average man has over 4,000? But that is not the case for our next guest. At 18, he discovered he couldn't achieve orgasm. Now he's 36 and says he's had less than 20 orgasms ever with a partner. Ben joins us now via Skype, along with OBGYN Dr. Millie Behera in our studio. Ben, thanks for being so open and honest about this. I want to ask you, the first time you knew something was wrong.
It started when I was 18, when I first had sex, and that's how it was, and that's how it carried on for the rest of my life. So I'm kind of resigned to the fact that that's how it is.
Ben, thank you for your bravery in sharing your story, and we appreciate your speaking with us. I guess just so we can understand a little better, are you able to achieve orgasm when you self-pleasure and just not with a partner?
It's easier on my own, but it's universally difficult. I think it's fairly common with most people that it is easier on their own. And it's just that for me, it's hard to start with, and then it just gets even harder when I'm with a partner.
Ben, you've seen a urologist and you've been checked out. I mean, there's no anatomic, physiologic reason why you should be having this problem, correct?
Yeah, that's correct. And that gives me a lot of confidence. You know, I've tried everything. I've tried every test going. I've tried hypnotherapy. I've tried working with a coach. I've tried all sorts of kind of men's groups. I've tried working with a sex coach itself. There's nothing wrong with me. And that's kind of led me to believe that this is something that mentally exists, something that I've held on for whatever reason to from the age of 18.
I think that's a great point, Ben, is it's nice to know that you found that it's reassuring that there's no underlying cause that leads to, that knowing that there may be an issue with the parts or the function of everything together. I know that you are thinking about future fertility options as well and have had questions about that, but that is also a good sign that you may have good future fertility options and be able to explore that if and when the time is right.
But let me comment really quickly, Ben, because the reason I feel for you so much is because women may not realize how much pressure there is on a man, because men are supposed to always perform and always succeed, and the assumption is that something is wrong with you if you can't reach orgasm, or a woman might take it very personally. Most men have a powerful camera on their...
So again, just the idea that this happens to men too, and we don't talk about it as much, right? This next one, I wanted to bring up briefly because this is not in the DSM, but there are people who have uncontrollable orgasms. There are people who have sort of the opposite issue. And I think because of sort of the same type of narratives, the doctor on the doctors was just saying, we don't consider these equally problematic, but you'll see that they actually do interfere with people's lives.
The following program contains mature subject matter. Viewer discretion is advised.
This is about a loss of control down there. It's a bizarre story. 28-year-old man anonymously shared his story with Men's Health, explaining how his constant involuntary orgasms were ruining his life. He was experiencing as many as 10 orgasms throughout the day. So, seems silly, and we've talked about this in women before. First time we've talked about it in men. What's going on here?
Well, this is the same thing that's going on to the women that we've discussed, but you hear about it so much less frequently. Maybe because men kind of tough it out, or maybe because men are wired a little differently. But this really is about how we're wired sexually. The nerve connections that go from our spine to our brain and down to our genitals. So when a person has this condition, they feel constantly aroused, but it's not a wonderful sexual thing. It's a really an annoying, and in some cases, it's a very painful thing, kind of like restless leg syndrome or sciatica. We believe that there is an abnormality in the spine where the signals are coming from the penis to the spinal ejaculation center to the brain, and there's a bulge in a disc or a cyst that's pressing on the nerve. It's like short-circuiting the nerve, and the brain doesn't know that this signal is coming from the spine. It thinks it's coming from the penis, and the person thinks that they're just sexually aroused all the time or getting stimulated or irritated in their genitals, but it's not in the genitals, it's higher up. And it's short-circuiting what should be just a normal sensation. And it's very irritating, it's very debilitating, and it can really lead to suicidal ideation in some cases.
So it's really
Yeah, unfortunately, when I was Googling videos to show for this, or YouTubing, I guess, one of the videos I saw was a woman who had this disorder where she was constantly orgasming, who did die by suicide. So again, I think we have this idea in our society that like there's never too much of a good thing in terms of orgasms, but obviously if it's something you're not wanting, just like anything else, it can be problematic, right? The next one we're going to talk about is genitopelvic pain / penetration disorder. And so this is a set of dysfunctions that don't fit neatly into specific phase of the special response cycle. There we go. And are characterized by enormous physical discomfort during intercourse, persistent or recurrent difficulties with one or more of the following. So penetration during intercourse, vulval or vaginal or pelvic pain during intercourse or penetration attempts, marked fear or anxiety about getting pain in anticipation of, during, or as a result of vaginal penetration, and marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. And so this is sometimes called vaginismus, where the person's vaginal muscles will actually contract. And it's almost like a little, it's not orgasmic, but it's like self-protective. And so these folks it may even be difficult for them to get like typical annual OBGYN exam, because it can be hard for the OB to get the speculum in there. Symptoms have to last for at least 6 months to be diagnosed, and you've got clinically significant distress. Specifiers here, there is a specifier for this being lifelong, nothing tragic going on. So basically, since they were sexually active or acquired, and acquired would be maybe they've had a period of relatively normal sexual functioning and then something goes wrong. Maybe they've had a physical condition or unfortunately some sort of trauma. So for some women, this is related to sexual or physical abuse. And it can onset with a history of like a vaginal infection, like a yeast infection, a bacterial infection. One of the factors that women will see, and we'll see it as a risk factor, but then obviously it keeps going, is pain during tampon insertion, or actually being physically unable to insert a tampon, so they have to wear pads. Okay, so now we're gonna talk about treatments for these in general, and actually, David, you mind flicking the light back on, just because it's a while before a video and it's kind of getting dark outside, so. Okay, so modern sex therapy is short-term and instructive. It'll be like 15 to 20 sessions that usually if you're going once a week is about 6 months. So again, contrast that to old psychodynamic therapy where some of this stuff would be like years of laying on the couch, right? And it's centered on specific sexual problems rather than on any kind of broad personality issues. And modern sex therapy includes assessing and conceptualizing the problem. So during your intake, in addition to sort of your typical intake questions, you'd also ask a sexual history. When were you first sexually active? Do you have any history of abuse? You know, when are you having issues? When did those issues begin? You also, if they are with a partner, you assign mutual responsibility for the partner, for the problem. So typically, let's say the man in a heterosexual relationship is having erectile disorder, then it's like, oh, it's your fault, right? Or the woman is having pain disorder, or it's your fault. And the idea is both partners are sharing this problem and they're going to work on it together. The therapist will do a lot of education about sexuality and sexual performance, talk about physiology, talk about various techniques. We'll work on attitude change, really challenging myths like you heard in the video we watched. A man is always interested in and ready for sex. Or if a woman can't have an orgasm quickly and easily, there's something wrong with her. Or all touching is sexual and should lead to sex. You try to eliminate that performance anxiety in the spectator role, one by naming it, and two by trying to help people do more in the moment. And sometimes what you'll have people do is what's called non-demand pleasuring, where they go home and either by themselves or with their partner masturbate, but not to completion. Just sort of get used to touching their body with a good sensation. You increase communication skills around sex, but also just in general, right? Get people talking to each other, give each other instructions during sex in a productive manner. You try to change destructive lifestyles and marital interactions, so work on that relationship in general. You know, if it's not an open relationship and there's cheating, you're going to need to address that. And then, you know, one of the things you do really at the start, I don't know why it's here at the bottom, is in addition to doing your own sex history, you refer for medical tests, and simultaneously you would have them working with a physician to address any physical and medical factors that are going on. All right, so this is a very brief video.
My name is Claire Postel, and I'm a licensed professional clinical counselor and AASECT certified sex therapist. Talking about sex is taboo and often difficult for people. At the first appointment, we will discuss some of the patient's presenting concerns, as well as a history of the problem. It is really just an opportunity for us to get to know one another and gain a comfort in talking about these difficult topics together. I will often provide patients with a treatment plan based on their reported concerns, and we'll discuss the needed commitment for therapy. Homework is something that I often give in sex therapy. I ask people to commit to doing their homework 3 to 4 times per week. Sometimes patients are expecting me to assign sex for homework, but that is rarely the focus of homework. Sex therapy can be for an individual or for a couple. If a patient isn't partnered, we'll focus our time in therapy on things that can be done individually. However, if a patient is partnered, it is encouraged that their partner attend the appointment. Talking about sex is difficult, but at Ohio State we provide a safe place for patients and partners to share and work through their concerns. My name is Claire Postel, and
So again, you see, fully acknowledging this is hard for people to talk about, particularly in the US. I think we have like this really weird relationship with sex, right? Where it's like, we talk about it, but only in the abstract, right? We have like jokes about it and stories and movies about it, but like a lot of times people don't feel comfortable just like talking about sex, right? So fully acknowledging that at the start of therapy. So in addition to the universal components of sex therapy, there are specific techniques that can help in any of the sexual dysfunction areas. So for disorders of desire, These can be among the most difficult to treat because of the many issues that feed into them. So we'll use a combination of techniques. Affectual awareness is awareness of your own emotions and how those might be impacting desire. Self-instruction training. So learning what you actually like. A lot of people have never taken the time to do that. Behavioral techniques, insight-oriented exercise to sort of help people realize anything that might be a barrier. And again, looking at, do we need biological interventions, maybe hormone treatments, things along those lines. For erectile disorder, we're looking at reducing that performance anxiety and or increasing stimulation. You can do what's called the tease technique, where you sort of work up to it. The most common treatment here is the biological one, in particular, sildenafil or Viagra. And so that is one of the most prescribed medications now. Other biological approaches have been around for decades and decades, and these include gels, suppository, penile injections, vacuum erection devices, and you can even get penile implant surgery. So again, say you have a spinal cord injury, you're never going to be able to get an erection on your own again. You can actually get an implant in there. And then my understanding, so it's kind of like, I don't know, again, I'm dating myself, but if anyone ever had those shoes where you pumped it up to make them fit better, they had like little air pockets. It was a thing in the 90s. But it's like that, but for your penis. So, allows the person to be in control of their sexual experience. And then for male orgasmic disorder, you would again focus on techniques to reduce that performance anxiety and increase stimulation. And when the cause of the disorder is physical, you could include a drug to increase arousal of the nervous system. For early ejaculation, this has been successfully treated for years using a behavioral procedure like the stop, start, or squeeze techniques. So these techniques involve bringing the man to arousal and stopping before ejaculation, backing back off, bring it back up so he learns essentially how not to just ejaculate right away. And so then that's repeated so that they experience stimulation for longer than before. And after 2 to 3 months of doing this, either alone or with their partner, they can have prolonged intercourse. Some clinicians actually will use fluoxetine, Prozac, and other SSRI drugs for early ejaculation. So these drugs reduce sexual arousal or orgasm in folks. So for that reason, they can delay early ejaculation. However, we don't have long-term outcome studies on like whether taking an antidepressant when you're not depressed is going to like mess up your system long-term. So something like Viagra, which sort of works short-term, might be better. Well, I guess for other things, for early ejaculation, you don't want Viagra. Sorry. So female orgasmic disorder, you want specific treatment techniques that include things like self-exploration, enhancement of bodily awareness, directed masturbation training. The lack of orgasm during intercourse is not necessarily a sexual dysfunction in and of itself, provided that the woman is still enjoying the process and is orgasmic, perhaps through other means, again, clitoral stimulation. And for this reason, some therapists believe the wisest course of action is to simply educate women whose only concern is lack of orgasm through intercourse. Like, this is your clitoris. This will make you feel good. I mean, again, it sounds kind of silly, but people don't get this in sex ed, right? Alrighty, so I believe this was in the late 60s, early 70s. There's a whole show about it called Masters of Sex. Masters and Johnson really developed early research in this area, and we've now moved beyond that. So for example, Masters and Johnson would only do treatment with married couples. But therapists will now treat unmarried couples, those with other psychological disorders, couples with severe marital discord, the elderly, the medically ill, the physically handicapped, clients with LGBTQ+ orientations, and clients with no long-term sex partner. So we've expanded our client base essentially. Therapists are paying more attention to excessive sexuality, as I mentioned previously. So having too many orgasms or like sex addiction. And the use of medications to treat sexual dysfunction is controversial and troubling to many therapists. And they're concerned that many clients and doctors will just be like, oh, here's a medication, this is easy, go take it. When in fact, people might benefit more from a more integrated approach. All right, so next we're going to start talking about the paraphilias. And so these are an interesting mixed bag of like very disturbing things and some things that, like, depending on whether or not it distresses you, might not even be a disorder. So these are disorders that are characterized by unusual fantasies and sexual urges or behaviors. They're recurrent and sexually arousing. They can involve things like humiliation of yourself or your partner, children or other non-consenting people, and non-human objects. According to the DSM, paraphilia should only be diagnosed when they've lasted for at least 6 months. And in most of the paraphilias, when the urges, fantasies, or behaviors are causing great distress or impairment. That being said, there are some exceptions to that rule. So for example, pedophilia, I don't care, the DSM does not care. If you yourself are distressed by that, you are harming someone else, and therefore it is a paraphilia, right? So sexual conduct with children, sexual abuse of children, let's be honest, right, is not like acceptable because of this disorder. Some people who have one kind of paraphilia will display others as well. And these are actually, I believe, in the DSM-5 referred to as paraphilic disorders. Relatively few people will receive a formal diagnosis because most people just don't come for treatment for these. But clinicians believe that some of these patterns may be quite common. And although theorists have proposed various explanations for paraphilias, there's little empirical evidence to support any of these explanations. Again, largely because the population we have to study is so small because people just don't talk about it. None of the treatments applied to paraphilias have received much research either, or have been proven very effective. And psychological and sociocultural treatments have been available the longest, but we're also using some biological interventions. So this is like the overall for paraphilic disorders ideas of what the criteria are. So again, 6 months at least. They have recurrent and intense sexually arousing fantasies, urges, or behaviors involving objects or situations outside the usual sexual norms. So again, non-human objects, non-genital body parts, that's where your foot fetishes are, right? The suffering or humiliation of oneself or one partner, a child or other non-consenting person. And then significant distress or impairment over these, and some paraphilic disorders like pedophilic disorder, exhibitionistic disorder, voyeuristic disorder, frauduristic disorder, and sexual sadism disorder. The performance of the paraphilic behaviors indicates a disorder, again, even without distress or impairment. Alrighty, so go ahead and kill the light again. And this is a short video just sort of explaining some of the, it's going to talk about like paraphilic behavior and also paraphilic disorders sort of roped into one here.
These are all the typical sexual attractions and behaviors. Then what is all this around it? They're called paraphilias. Para meaning besides, and philia referring to love. You may be thinking, isn't this a fetish? Fetishes are a type of paraphilia. It's attraction to body parts or inanimate objects. It's kind of like in geometry, the way that a square can be a rectangle, but a rectangle could not be a square. Fetishes are the square. There are lots of fetishes. There are over 500 paraphilias. 500 plus ways that people experience love and pleasure beyond this.
And again, that doesn't mean there are 500 paraphilic disorders.
Pornophilia is erotic interest in turning someone into furniture. Don't worry, Stefan, I'm not going to skin you. Someone making obscene phone calls for erotic pleasure is called telephone scatology. This is not to be confused with another paraphilia known as scatology, referring to arousal by feces, better known as coprophilia. We're not going to demo that. The sexual desire to dress and act like a baby is paraphilic infantilism, or the adult baby syndrome. Trichophilia is specifically the diaper, a diaper fetishism. Plesiophilia is attraction to stuffed animals, the toys, not the taxidermy. Kleptophilia, stealing for pleasure. Oculophilia, breast fetishism or masophilia, pygophilia, the butt. These are all different types of partialisms, a type of fetish where it's for a specific non-genital body part. The most common paraphilias are frauderism, rubbing on a non-consenting person. Sadism, pleasure from inflicting pain. Masochism, pleasure from the pain, which can also be psychological. Transvestic fetishism is wearing the clothing of the opposite sex. Exhibitionism is exposing oneself. Voyeurism, watching others undress, be naked, or having sex. Antagonistophilia. The seventh of the most common paraphilias is pedophilia, sexual arousal, attraction, and gratification derived from prepubescent kids. This is not to be confused with hebephilia, which is early to mid-puberty, or ephebophilia, which is late puberty. This book, well, the professionals and scholars that put it together and the preceding editions, has the say on when a paraphilia is unhealthy. The psychiatric community uses the Diagnostic and Statistical Manual of Mental Disorders to evaluate clients and patients. For short, it's called the DSM-5. It's a guidebook for a lot of mental disorders. It's also the guidebook to determine when a paraphilia is disordered. Mainly answering the question, is it causing or risking harm, impairment, or distress to anyone? If yes, get treatment. If no, confirm consent. Even when a paraphilia isn't harmful, it can still be qualified in a variety of ways. One system describes 3 levels: paraphilias that are optional, preferred, and exclusive. Optional, which is kind of a take it or leave it system. Preferred, where the person would rather incorporate the paraphilia into their sex play than not. And exclusive, where the only means of sexual gratification, attraction, or arousal are going to come when that paraphilia is present. If paraphilia is not there, not getting off. My hope is that with increased awareness about paraphilias, people won't be ashamed of their differences or their requests for something specific. They'll get help if they need it, and they'll meet communities that understand them. Paraphilias, no shame. The website fetlife.com is a community where this is already the reality.
So again, like,
And these are-
paraphilias don't have to be a disorder, right? But there are some that are automatically disorders because they harm other people. And so we're actually going to start with well, no, we're not starting with them, sorry. I thought voyeurism was first. But fetishistic disorder is one that can go either way. So there are people who have fetishes, but it doesn't distress them. And again, as long as your partner is consenting, awesome, go for it. So the key features here are recurrent intense sexual urges, sexually arousing fantasies or behaviors that involve the use of a non-living object or a non-genital body part. So it usually begins in adolescence, and almost anything can be a fetish. Women's underwear, shoes, and boots are especially common. Psychodynamic theorists will view fetishes as defense mechanisms, but therapy using this model not surprisingly, has been largely unsuccessful. Behaviorists propose that fetishes are learned through classical conditioning. So you can treat them with aversion therapy, where you do something like apply a small electric shock when you imagine the object of your desire, or covert sensitization, where you pair an object of your desire with an imaginary aversive stimulus. And other types of exposure therapy. Another behavioral treatment is masturbatory satiation, in which you look at the fetish object and just masturbate and masturbate and masturbate till it's boring. And for some people that works. Additional behavioral treatment is organismic reorientation, a process which teaches individuals to respond to what they consider more appropriate sources of sexual stimulation. And again, unless this is distressing to you, fetishism isn't necessarily a disorder. Transvestic disorder, I would say, is the one that's the most confusing for people. So this is not being trans. This is getting your sexual pleasure from cross-dressing. So this is characterized by fantasies, urges, or behaviors involving dressing in the clothes of the opposite sex in order to achieve sexual arousal, or I should say other sex, since we know there are more than 2 sexes. The typical person with transvestitism is a heterosexual male who began cross-dressing in childhood or adolescence, maybe just sort of like for funsies or in a school play or something like that. Transvestitism is often confused with gender dysphoria, but the two are separate patterns. So in gender dysphoria, you're dressing like a different sex because it's gender affirming, it matches who you are inside. Here you're dressing like a different sex because of sexual arousal. And some part of me wonders if this confusion is part of why people are like, drag queens are dangerous, right? Because drag queens are also not dressing up to get off, that's a performance art. And so, you know, we just need to be aware of the differences here. The development of this disorder often seems to follow the behavioral principles of operant conditioning, where someone might be reinforced for cross-dressing. All right, exhibitionism or exhibitionistic disorder is one of the disorders that we don't care whether you're disturbed by it, it's problematic. This is characterized by arousal from the experience of exposure of your genitals in a public setting. So this is also known as flashing. And now this doesn't necessarily mean the drunken people who strip down and run across like sports fields, right? Because they're not necessarily getting a sexual charge out of it. These would be people who like the act of exposing themselves to someone else is arousing. Sexual contact is usually neither initiated nor desired. They just want to show off. It usually begins before the age of 18. It's most common in males. Treatment here generally includes aversion therapy and also masturbatory satiation. But it can be combined with orgasmic reorientation, also social skills training, perhaps to get someone's attention. You could talk to them instead of, you know, flashing your junk at them. Or psychodynamic therapy. All right. Voyeuristic disorder is characterized by repeated and intense sexual desires to observe people in secret as they undress and or to spy on couples during intercourse. So it can be just having like fantasies about doing that, or it can be becoming a peeping Tom and actually looking in on people. The person may masturbate during the act of observing or when they remember it later. The act of discovery actually adds to the sexual excitement for these folks. A little buzz there. This is something that psychodynamic theorists propose that the voyeurs are trying to seek power. Others have explained it as an attempt to reduce castration anxiety. Behaviorists try to explain it as a learned behavior that can be traced to perhaps a chance and secret observation of a sexually arousing scene. So you did it on accident once, it turned you on. Now this is how you get off. All right, freuderism, you heard, or freuderistic disorder, you heard her mention in that video. They have fantasies, urges, or actually act on behaviors involving touching or rubbing against a non-consenting person. And that non-consenting person obviously makes this one a paraphilic disorder, even if the person isn't distressed by it. This person is almost always male, and the person fantasizes during the act that they're having a caring relationship with the victim. When I rub my junk on someone, I just imagine that some of these are really hard to wrap your head around, right? This usually begins in teenage years, and this generally decreases or even disappears by age 25. All right, and obviously I've mentioned pedophilic disorder several times. This is the most problematic. I think I've mentioned to y'all before, even before I had my own kid, anything that damaged kids really ticked me off. And this one in particular really ticks me off because I unfortunately, while I was a therapist, saw a lot of people who had been the victims of pedophiles when they were growing up. And it has a lot of ramifications in terms of PTSD, eating disorders because of unhealthy relationships with their bodies. So some of my clients who had been abused as children purposely gained weight because they thought they might be unattractive if they did that. And some of them purposely lost weight for the same reason. So it was self-protective. So this pisses me off that there are people who act on this. So it's characterized by fantasies, urges, or behaviors involving sexual activity with a prepubescent child, usually 13 years of age or younger. Some stick to child porn. That in and of itself is a offense. That's actually how they got Josh Duggar, was he had child porn on his computer. He was never really prosecuted for sexually abusing his sisters. Others are driven to watching, fondling, or engaging in intercourse with children. Again, this disgusts me. Evidence suggests that 2/3 of the victims are female. And again, this does not at all diminish what happens to young boys. We think about the case of the Boy Scouts, we think about the Sandusky case, right? But unfortunately, I think sometimes those boy-related cases get more publicity. Whereas again, girls are 2/3 of the victims, so we don't want to forget them. So you have some specifiers here. Some people are exclusively pedophilic, so they would only get off to children. Some are non-exclusive, so they might have typical sexual relations with other adults, but then also be attracted to children. Another specifier is whether they're sexually attracted to males, females, or both. And another specifier is whether it's limited to incest. Incest is specifically someone to whom you are related. And unfortunately, incest, but also just like someone you know, are the most common. If it's not a father, an uncle, a grandfather, a cousin, it's like a family friend. Or, a priest or something along those lines. I forgot about this for a minute. So in 2013, when the DSM-5 was printed, they had a typo where they referred to this as a sexual orientation instead of, a sexual dysfunction, a sexual paraphilia. And so they had to print a retraction. Sexual orientation is not a term used in the diagnostic criteria for pedophilic disorder, and it's used in the DSM-5 text discussion is an error and should read sexual interest. In fact, APA considers the pedophilic disorder a paraphilia, not a sexual orientation. This error will be corrected in the electronic version of the DSM and the next printing of the manual. APA stands firmly behind the efforts to criminally prosecute those who sexually abuse and exploit children and adolescents. We also support continued efforts to develop treatments for those with pedophilic disorder with the goal of preventing future acts of abuse. Like, just get a copy editor. How hard is it, right? But obviously horrific that was even in there. People who have pedophilic disorder typically develop it in adolescence. Some, but not all, were abused themselves as children. Many were neglected, excessively punished, or deprived of close relationships in childhood. So even if they weren't sexually abused themselves, they experienced other forms of abuse. Most are immature, display faulty thinking, and have an additional psychological disorder. And some theorists have proposed as a result that there's maybe some sort of biochemical or brain structure abnormality. Most people who are caught who have pedophilic disorder are imprisoned and or forced into treatments. Treatments here include aversion therapy, masturbatory satiation, and orgasmic reorientation. CBT here involves relapse prevention training, and it's sort of modeled after substance abuse treatment. Alrighty, so we're not going to watch this whole video, but I thought that this was weirdly interesting. So this is about guys who have pedophilic disorder but don't act on it.
I wish people understood that, we generally don't like the fact that there are pedophiles either. Like, we didn't ask for this. It's something that a lot of people will be more comfortable ignoring, but when it's you, it's not really an option to ignore it.
This is David. He's known as a non-offending pedophile. Someone who has a romantic and sexual attraction to kids, but says he's never abused a child. He wants help, but getting it in the US is risky.
When I was figuring this stuff out about myself, I decided that I couldn't tell anybody because I was pretty certain that at best they would like desert me and just like I'd lose a friend or whatever, and at worst like they'd tell absolutely everybody and I'd be like,
it'd be dangerous for you.
It would be dangerous.
We've never thought about non-offending pedophiles. We focused all of our resources on after-the-fact interventions. How do we punish? How do we surveil? How do we keep track of sex offenders? What we need are interventions that can target the vast majority of sex crimes that can be prevented.
Dr. Letourneau is one of few researchers in the US focusing on preventive measures to help pedophiles. But getting them treatment is tough. Mandatory reporting laws in America require that therapists alert authorities when they suspect a pedophile is at risk of abusing a child.
If you are someone that has an attraction and you go to a therapist and you say, I have these attractions for young people, what could happen?
Any number of things could happen. Even if you've never offended, if you're sexually interested in children, you reach out to a therapist for help, they may decide that you still represent a threat and that their concerns meet the threshold for a mandatory report. I know of a child who's at the age of 15 disclosed to his school guidance counselor that he had sexual interest in young children and he wanted some help and support around that. He got kicked out of school, and they assumed, as many people do assume, that someone with sexual interest in children, that they cannot control themselves, that they will just reach out and grab the first child they see off the street and rape that child. And that's not true.
This is a PSA you're not likely to see in the US.
Do you like children in ways you shouldn't? There is help.
The campaign was produced by Prevention Project Dunkelfeld, one of the only places in the world that offers therapy to pedophiles.
We do not have these mandatory report laws as you have in the United States.
Yes.
This is an obstacle for prevention work because nobody would show up.
Since 2005, about 10,000 people in Germany have reached out to Dunkelfeld for help.
Is this like conversion therapy? Are you trying to cure these people?
No, it's not possible to change sexual orientation. I never would try that.
So are you saying that pedophilia is a sexual orientation?
Exactly. We have a lot of sexual minorities, and this is all part of
Maybe this guy edited the DSM. I don't know.
this huge variety. So nobody chooses this. And as long as he not would act out, it would be very, very inhuman to judge such a person. And I would always vote to integrate him in society.
Dr. Bauer estimates that 1% of the population is pedophilically inclined, and nearly all of them are men, but not all of them offend. Dunkelfeld's treated about 1,700 since it opened.
And what does this treatment look like?
It's a kind of cognitive behavior treatment running to all the risky situations, and then we will train him to change his behavior in these situations. The other one would be pharmaceutical options. We can lower sexual urges with very effective drugs. So if it's...
Is that like chemical castration?
It's like chemical castration, yeah.
How many people have gone through this program and have not offended?
Nearly all of them.
How do you measure that?
By just giving the, taking the answers of them. It's subject.
Oh, so they tell you?
Yes.
Doctor, is that, if you're just relying on them to tell you that they didn't act out as the only measurement of success for this program,
yeah,
is that enough?
As long as we do not have any other measurements, and we are working on this.
So that gives you, again, sort of an interesting perspective on this. I would not say it's a sexual orientation, but I like the idea of people being able to recognize that they have this and that it's potentially harmful and seeking help, right? And yeah, mandatory reporting laws in theory could get in the way of that if we're going to overuse them. As a therapist, you're not supposed to report unless the person has actually harmed a child, right? Or is just about to harm a child. So the idea that you could be able to work with someone, I think that's really important. All right, so now I'm going to talk about sexual masochistic disorder and sexual sadism disorder. And so one thing I should say here is that this is extreme versions of BDSM, and if people are engaging in consensual and safe BDSM, and both people are okay with it, neither is distressed by it, they have safe words, all that good stuff, that also is not a paraphilia. I'm putting it out there. So characterized by fantasies, urges, and behaviors involving the act or the thought of being humiliated, beaten, or bound, or otherwise made to suffer. This is sexual masochistic disorder. And most of these fantasies begin in childhood and seem to develop through some sort of classical conditioning. Now, sexual sadism disorder is one of the ones that if you don't have a consensual partner, it doesn't matter whether you're distressed by it, right? So they find fantasies, urges, or behaviors involving the thought or act of psychological or physical suffering of a victim sexually exciting. This is named for the infamous Marquis de Sade, and people with this disorder imagine they have total control over a sexual victim. Sadistic fantasies may first appear in childhood. The pattern is long-term, and again, seems to be perhaps related to some sort of behavioral conditioning, classical conditioning, modeling. Psychodynamic and cognitive theorists view people with sexual sadism disorder as having underlying feelings of sexual inadequacy. Biological studies have found possible abnormalities in their endocrine system. And the primary treatment here is aversion therapy. And so just a general word of caution about the paraphilias. The definitions of paraphilic disorders, like those of sexual dysfunctions, are strongly influenced by the norms of a particular society in which they occur. And some clinicians argue that, except when people are hurt by them, many paraphilic behaviors should not be considered disorders at all. Give you an example. In the early 1970s, homosexuality was a paraphilia. Are we ashamed of that history as psychologists? Hell yeah. Did it lead to years of people suffering through conversion therapy? Yes, even when that disorder was no longer in there. And so we need to sort of recognize that, you know, maybe down the road, like fetishism won't be a disorder. People just be like, don't yuck somebody's yum, whatever. Alrighty, so we will finish. I have one more slide where we're going to talk about gender dysphoria. And so we'll finish that on Thursday. And then we will start talking about, I believe, schizophrenia next. Yes, schizophrenia.